Wonderful. Got to get all these people out of the way. Welcome, and I can't see you, so I'm just going to talk, and I will trust that if there's questions, they will be asked by our facilitator. Um, so I was asked to present on assessing suicidality of substance use clients, and the first thing I want to share is we should assess the suicidality of anyone. I do not have disclosures to acknowledge. Our learning objectives is to identify why we assess for suicidality, understand the risk and what increases the risk in said population, and learn about the various suicide risk screeners. Um, I will attempt to do person first language, and I know I've been in the field for over 30 years, and sometimes I slip. So I want to remind everyone to attempt that every single day. Words really are important. So we're going to spend about the next 20 minutes and I'm going to present on this. I've given you great resources and I encourage anyone at any level of practice to look at the various screeners and look at the resources. One of the things I will share is we screen for suicidality because it overall reduces the risk. It helps us detect what early risk there might be, and it allows for interventions to be created that are person-centered. It also encourages disclosure and it breaks that stigma and silence about I shouldn't have these thoughts or I can't, as a clinician, ask these questions because I might make it worse, which are two myths. So why do we screen in SUD? We screen because client safety is a priority. We also screen because what we know is that individuals with substance use disorder exhibit a lot of hopelessness. They exhibit suicidal thoughts and behaviors, and the risky behaviors are higher than the general population. Therefore, anyone working with SUD clients needs to be trained in suicide risk screenings and feel confident using those screeners. So, what is that increased risk? These are key findings from 2024, and we found that there's a significant elevated risk in SUD clients. The risk is pronounced with people that have multiple substance use. And as we all know, working in the addiction field right now, the substances themselves have become more lethal. So, even an unintentional overdose could be magnified. We also see a correlation, and I gave you lots of studies to look at, but the Pew study, Pew Trust, shows that people with opioid use disorder were 1.86 times more likely to experience suicidal ideation than those without an opioid use disorder. And people that have co-occurring disorders, again, have an elevated risk. So somebody that, for example, has 35% of individuals who made a suicide attempt also had a substance use disorder, and 72% of the individuals with a substance use disorder also had that trauma associated with their life. So we all know our cases are complicated and we need to feel comfortable screening for suicide. The official numbers for suicide rates in Idaho are always delayed by a year or two. Participants unable to translate, speak. Um, Idaho, the data is delayed, but in Idaho in 2024, we saw another 1.6 to almost 2% increase in the suicide rate, and we are higher in Idaho than the national standard, national rates. And those risk populations, as we probably can imagine, are youth, and that's defined as 18 to 24-year-olds, the middle-aged men, which are 25 to 54, our veterans, our seniors, and individuals with substance use disorder, unfortunately make up the population that is demonstrated a higher risk of suicide. Does my screen froze? Oh, there it goes. So why is that risk increased in SUD population? It's increased because we see impulsivity and impaired judgment. That's one of the direct correlations with alcohol and drugs. It impacts that brain function. It inhibits judgment. It increases impulsivity. And particularly people that are intoxicated, we see impaired judgment. We also see the underlying mental health conditions, the comorbidity of depression and anxiety for people. We see exacerbation in that overall distress during withdrawal. So people that crash for periods of time after using substances, that hopelessness is there, agitation, depression, and all of that will heighten the significant risk of suicidal ideation and intent and plans and actions. We see increased isolation and stress in people with substance use disorder. That is on top of normal stress and anxiety, and the access to lethal means. The substance itself is a lethal means. So if somebody is feeling hopeless and needs attention and a plan, unfortunately, our drugs are a good cause for that. So what are the benefits of setting up screening in your practice, whether you're in private practice, whether you work with a group of people? It's not hard to set up a screening process, and everybody should have a screening process and know what your scope of competency is and who you're going to refer to. Because it's not if you will have a person with suicidal ideation, it's when you will have that person. So the benefits are that early detection and intervention. What we've seen is substance use disorder patients decrease their suicidal risk by 30% if you start to talk with them and do early interventions. Early screening allows us to create really tailored treatment plans for the individual based on their overall comprehensive treatment plan. It can include their mental health services, medication services, developing safety plans. Um, we also can improve outcomes by having these screeners. Failing to address suicidality puts the person at greater risk. And the ethical and professional considerations, you can have more ethical and even legal ramifications if you're not screening and appropriately referring. Screen gets a little jaggy here. So, if you have not learned this yet at any point, this is a great one to put into your repertoire. Sometimes with newer clinicians or recovery coaches, peer support, joining the field, we just talk about this overall that these are the risk factors. If you're male, if you live alone, if you have had a family history of suicide, the things that we recognize, unemployment or recent loss of income, a history of physical, sexual, or emotional abuse, not being responsible for people under the age of 18. If you've recently harmed yourself, if you've recently had insomnia or wishing you were dead, anniversaries of important losses, these are things that we think of and it's like, man, this is overwhelming. How do I put all of these things into my mind and think about how to screen for them? So I'm going to give you resources of screeners that are easy to administer and you or your organization can utilize them. So the first screener that is really helpful is the PHQ-9. And the recent analysis of the data that's come out from both the general population studies and the Veterans Health Administration for our servicemen and women is that the PHQ-9, item number 9, that's the standalone question, is able to screen out and needs to be used so that you can then go into that additional information that should allow you to reduce the risk. So if you're not familiar with the PHQ-9, it asks things like, have you had limited interest or pleasure in doing things? Do you feel down, depressed, or hopeless? Are you having trouble falling or staying to sleep or sleeping too much? Are you feeling tired or having a little energy, poor appetite, or overeating, feeling bad about yourself, trouble concentrating, moving or speaking so slowly other people could have noticed or the opposite, being so fidgety and restless that you're moving around a lot more than usual. If you were just stopping there, those could mean so many different things. But when we get courageous and ask that last question of, have you had thoughts you would be better off dead or of hurting yourself in any way? That question alone opens up an entire conversation and a risk analysis that you need to do. The other evidence-based screeners that you could utilize would be the Columbia Suicide Severity Risk Scale, or the Ask Suicide Screener. And then there's other tools like the Patient Safety Screener, and it's got 3 questions. But I'm going to give you a couple of the other evidence-based risk screeners in case you haven't seen them before. The Columbia Suicide Severity Scale, it's widely used. Again, it's very well researched, all of these are. And it's a series of simple language questions that can allow you to feel comfortable as well as the person that you're screening. All of the tools that I gave you are free online, and there's free training available for whatever you or your organization needs to do. The key parts of the Columbia screener are that it assesses a full range of suicidal ideation and behaviors. It defines the severity and the immediacy of risk and what you, as a clinician, staff person, military personnel, what you should be doing next. Um, so the questions are in a decision-making tree for this one. You always ask questions 1 and 2, and you ask the patient or the individual that you're working with to think about in the past month. And you ask, have you wished you were dead or wished you could go to sleep and not wake up in the past month? And have you actually had any thoughts about killing yourself? And if they answer yes to question 2, you go on to the other questions, which are 3, 4, and 5, which then helps you figure out, have you been thinking about how you might do it? So that's the start to narrow down what the plan is. And have you had these thoughts and had more intentions of acting on them? So how often are they thinking about it? How lethal is that idea that they have? And then the next one is, have you started to work out or have you worked out the details of how you would kill yourself? Um, and then do you intend to carry out that plan? So it just a funnel of questions that lead to more severity. And then no matter what they answered to question 1 or 2, you always go and ask, have you done anything, started to do anything, prepared to do anything to end your life? That would include, have they taken pills to just figure out what different dosages make them feel like, and if they have woke up, have they researched things on the internet? Have they tried to shoot themselves? Have they held a firearm at a certain angle to see if they could really do it? Have they cut rope and prepared to hang it? These are the things that are very uncomfortable and can be triggering. Even talking about this subject, you may have to take a few moments after this training, because if we've ever worked with an individual, this can be triggering. Um, and then you go on in this particular screener to ask in the past 3 months if they've done any of this. And then the most important part for any screener is, do you know what your immediate resources are? Do you immediately call for help, depending on the severity? Because sometimes you need to call 911. Sometimes you're working with a team of people and you need to call in the licensed behavioral health professional and say, hey, my recovery or my peer support person that I'm working with is saying the following things, and I don't want them to leave today without you assessing them. Sometimes they need to go to the emergency room and figure out what's the next step. So that's the Columbia screener. The other screener that I would like to introduce you to, because it just different settings fit different things, is the Ask Suicide Screener questions. This again is evidence-based. You can get it at the National Institute of Mental Health. You can just say Ask Screener Toolkit and it'll pull it up. It takes, 20 seconds to administer. Again, there's a free toolkit. You can give this orally to a person if you're talking to them. Some people do this screener by handing a person a tablet and say, could you answer the following questions? This screener is validated to use as young as 8 years of old, all the way up into adults in a general medical setting, all the way to a mental health substance abuse clinic. If they answer yes to any of the four questions, it then triggers the layperson or the person with less credentials to seek out that next higher level of training and intervention by a clinician or medical provider. So the ask screening questionnaires are in the past week. So this one narrows down, instead of a month, it's a week. In the past week, have you wished you were dead? In the past weeks, have you felt that you or your family, whoops, sorry for the typo, would be better off if you were dead? And in the past week, have you been having thoughts about killing yourself? Or have you tried killing yourself? And if so, how, when, get that specific information. And then ultimately, if they answer yes to any of those four questions, you go on to ask the fifth question, which is, are you having thoughts of killing yourself right now? Um, and then for the ask screener, it talks about, and it in the toolkit, you can get this all on like a one handout that you could print and hand to somebody. You could keep it with you in your own caseload folder if you're out and about in the community and you're like, I feel like I need something to remind me. If the patient says no to any of the risk screeners, there's no necessity for ongoing clinical intervention. You would use your judgment to override if you think the person's not telling you the truth or there's other behavior that might mean that you need to go further. But if the questions are answered yes, then there's the opportunity to figure out, do you need immediate risk intervention, or do you need to have that person go straight to the hospital? Here are my references. I talked really fast, so you can see the references and different screeners. If you haven't already, there's the screening for suicidal thoughts and behaviors in trauma-exposed people with substance use disorder, and that's an entire addiction technology transfer paper that's been very helpful for people that are in any stage of this field. So thank you very much, and I will see if there's any questions. Let's
Debbie,
see.
thank you so much. That was a great presentation. Would you mind just while we collect any questions in the chat or anything, or give people a minute to talk, would you mind just touching on what you're going to cover in our next session? Because it's kind of like a continuation of this one.
Absolutely. So 2 weeks from now, I was asked to do safety planning. So in the next session, 2 weeks from now, we will talk about how you really create. So you've screened for this information, and what are you going to do to create a safety plan? And it's something that I'm going to teach that is very interactive between you and that individual, and that you need to get really comfortable having those respectful and digging kind of conversations, because a safety plan is not worth the piece of paper it's written on if it's not individualized to the particular individual and what they're willing to do, and what your resources are for your particular community.
Thanks, Debbie.
Hmm.
Um, okay, a couple questions, and Caitlin, I'm going to make you say yours out loud in just a second, but let's go to Deborah's first. Do you have available training to credential uh, oh, sorry, Deborah. I'm not sure if I understand what that one means. Maybe you're already answering the question, Debbie, of the developing a safety plans. And then Betty said, do not forget to screen coworkers if you see signs of stress.
Absolutely. The suicide risk screening is where, I mean, we're talking about it for people with SUDS, but this is for any particular person. So coworkers, family members, mhm.
And
Check
Caitlin,
in on people.
I'll turn it to you, and then we'll go to all the other panelists, see if you guys have other questions.
Yes, thank you so much, Debbie. What a great presentation as always. My question was, I have a lot of times uh peers that I'm working with when if you ask them the like basic like, oh, do you feel like killing yourself? Have you had any thoughts of self-harm? It kind of becomes like an intenser question because a lot of times like maybe they do have thoughts, but it's not so serious. And I've had other ones ask, like, is there any other questions you can ask that's not just like this straightforward, have you ever felt like killing yourself, to like maybe get the answers out of them without specifically saying that? Does that make sense?
It does. So I think what you're describing is how we don't shut people down into their shame or their embarrassment, and also be direct enough so that we can get accurate information. And so one of the things that I do early on when I'm connecting with people is normalize and give some statistics of why I might be asking these questions moving further into our relationship building is it is very typical in a substance use disorder to have thoughts of suicide. And then I kind of talk about don't be ashamed of that. I might share, knowing my client, an intervention that happened where somebody was able to be saved, but to normalize it so they don't feel alone and don't feel ashamed. But then we have to get comfortable doing that little push pull kind of thing. Like, gosh, it's going to feel really uncomfortable, but I'm going to ask you some really direct questions because I care about you and I am going to make sure that I can do what I need to do so that you're not no longer on this earth.
Thank you so much.
Hmm.
I think another aspect to kind of piggyback off of that is I've noticed just trying to normalize the idea and making the difference between passive suicidal ideation of these thoughts coming up of, I just don't want to do this anymore. Maybe it would be better if I wasn't here. And we can normalize that and open up the conversation of having that discussion of increase in frequency of those thoughts, doing that body and mind connection with those thoughts, the intensity of those thoughts, and really building that rapport. And I think starting this off really early, which for a lot of us, I think, at least in the clinical aspect, we hit on this pretty early on with the assessment process or the intake process, and having this be a regular and normal type of question. Um, I also go through a process too, and Debbie, I'd like your thoughts on this about what is the protocol? Because a lot of people might be really afraid to share what they're experiencing because they think that automatically means hospital. So even talking about it, they are very guarded because they don't want it to turn into this big ordeal. Yet feeling, hey, I am having this situation going on. So kind of going through that, what the intensity or that continuum is of suicidality as a whole.
Oh, I agree with you completely, Natalia, that one, we have to get comfortable, and those of us who have been through clinical training, we've been exposed early on. But I would really, practice having conversations, go back to your colleagues and say, I want to practice this. Will you be this type of a client? Will you role play this type of a client? And to know what your resources are in your particular practice, because our biggest fear is, oh no, I do not know what to do. So I'm going to jump immediately to the highest intervention, which is I'm going to call the life squad and I'm going to make them take you somewhere and you're going to lose all your autonomy and all your control over your life, which any of us, that's our biggest fear. So being able to feel competent in your own resources of what really is the risk and the better of a safety plan you can create, the more you'll feel comfortable letting that client go back into their environment. Or you can say, hey, here's a family member that we've already talked about is on your team. Can they go with you and reduce some of the risk in your environment if that's what you've identified? And yeah, so I agree. Being able to know what your resources are so that you don't put that person right into the highest level of care.
I think I also want to add to this that in a lot of my experience working with clients that do have suicidality, that it is more my discomfort than their discomfort in talking about how they feel. And so what I've seen is that if somebody is suicidal, they're more than likely going to tell me and not try to hide it because they also want help. And so making sure that we're managing our own feelings so that it's not impacting others.
I think I haven't looked at the statistics lately. There's that fear of like, am I going to know? There is a certain number of people that they're going to keep it very, very secret, very hidden. They don't have connection. They're very isolated, and they alone come up with a very lethal plan. And that's why, our veterans are at such risk, is because when they start down the hopelessness thing, they're like, oh, I've got to be tough. I'm supposed to do the world alone. And they already have some very lethal means that have been desensitized into their world, like their firearms and etc. So if you don't have somebody in your world asking you these questions, it can be like, oh, nobody knew. But when somebody's in relationship with others, we start to notice things. Somebody mentioned earlier about checking in on your coworkers. If we see changing behavior, it's easier to have that ongoing conversation and rapport, so you can get people engaged in a conversation sooner. So my takeaways are: come up with a particular screener that you and your organization uses. Um, get comfortable as possible asking direct questions with care and concern and support, because when we're uncomfortable, like, oh yeah, have you ever thought of suicide? Which is so much different than being able to look at the person and say, your life is heavy right now. You've shared with me X, Y, and Z, and I care. I am going to ask you questions, um, and then know what your resources are inside of your system of care. Know who you get to walk down the hallway with and say, gosh, I'm not sure about this. Will you join me in this care plan? Know who else is in the system.
Thank you, Debbie. I want to just take a moment to see if there are any questions or thoughts from our audience members. Oh, Misty?
Misty.
So thank you so much for the information. I really appreciate it. It's always good to get a refresher, and I didn't actually know about the 3-item screening. So thank you for that one. Um, and I appreciate you giving some of the stats. I just want to throw out there from my little corner of the world that queer folks in Idaho are especially at risk and also more likely to have substance use disorders and disordered use. And so make sure that you're considering screening that as a risk factor. I didn't see it on your other slides.
Thank you. Good
And
example. I was trying to keep it to 25 minutes, and every subpopulation, the queer community, we can look at our Native American and Indigenous population. So yeah, overall, everybody's at risk.
yeah, great
Thanks,
job
Chris.
today, though. You used your time very wisely and very useful.
Thank you.
Thanks, Misty. Debbie, thanks again. A great presentation today. And as we mentioned, Debbie will be back in 2 weeks to talk about how to actually develop those effective safety plans with your clients. So thanks for being here.